Hello and welcome to the session this morning about the rise in sexually transmitted infections. We're going to talk about what's causing this, where it's going, and what can be done about it, what is being done about it. I'm Tony Lays. I'm a Des Moines-based reporter for Kaiser Health News. I am joined this morning by Heather Metter, who's Lynn County Public Clinical Branch Supervisor, and George Walton, who's from the Iowa Department of Public Health's STI program. He's the manager. We are going to get into the discussion in just a minute, and we would welcome any questions that you submit via Hpv. First, we're going to watch a message from the sponsor of the session, the University of Iowa.
Welcome to the Iowa Ideas Conference. I am Kimberly Hunter, Interim CEO and Interim Associate Vice President of the University of Iowa Hospitals and Clinics. The COVID pandemic brought about exceptional challenges, such as worker shortages and healthcare disparities that really have changed the way we view healthcare. However, it has also highlighted opportunities for innovation and improvement. For example, we have seen a move towards telehealth, which helps us provide better access to care for all Iowans. We know that healthcare excellence is achieved through innovation and collaboration. And that is why we are a proud sponsor of this conference, and we are excited to hear your big ideas on how we can come together to improve quality of life and quality of care in Iowa. On behalf of the University of Iowa Healthcare, we hope you enjoy the conversations, make some great new connections, and leave inspired to help us shape the future of healthcare. Thank you.
We're going to start the conversation with George. George, talk to us about what the situation is in Iowa, how it happened, and how we compare to the country.
Yeah, thanks, Tony. I'd be happy to kind of set the stage here with a little bit of context. So in Iowa, there are three infections that are reportable to the state health department, 3 STIs. That's chlamydia, gonorrhea, and syphilis, and HIV as well, and I'll just touch on that for a little bit. But just to give you a sense for the numbers out there, because a lot of folks don't realize what we're talking about when we say that these are very prevalent infections or have high incidence, that they're quite common. So chlamydia, for example, looking at 2021 data in the state of Iowa, we had 15,619 cases. So that's quite a bit, and that is the most reported condition in the state and in the U.S. If you set COVID aside, of course, COVID became reportable and far outpaced any other infection we have. But other than that, chlamydia is by far the most common condition in Iowa and the U.S. And a little bit more about chlamydia. It's one that we see a bit more in women. So almost 2/3 of the diagnoses are among women. I think we'll talk maybe a little bit more about why that is, but I'll just put a little side note in there that we don't necessarily think that women acquire the infection at higher rates, but they are tested more often than males. So that's a key thing to keep in mind. But chlamydia is also one that primarily affects adolescents and young adults. So we really think about individuals who are under 25 years of age. That accounts again for about 2/3 of the diagnoses in the state. And we do see disproportionate rates with that infection by race and ethnic groups. So, for example, again, looking at the 2021 data, about 54% of the diagnoses were among persons who identified as white, 19% among Black populations, and 10% among Latino populations. And for those of you who are aware of the demographic makeup of Iowa, that doesn't quite match up, right? So if it were a proportionate infection, we'd expect that, 90-some% of the infection would be among white populations in the state. And staying on chlamydia just for one more second, we are in about the middle of the pack here when we look at the rest of the country. So we have to go back to 2020 to look at the national data because CDC is always at least a year behind. And we ranked 24th out of the 50 states in that year. So kind of in the middle of the pack there. I'd also like to talk about gonorrhea. So that is the second most commonly reported condition in the state. So in 2021, we had 6,404 cases or diagnoses reported. And that's after several years of increase. We did see a pretty steep increase in gonorrhea in the years preceding. Really that started to really jump up in 2018, but continued on. That infection we see a little bit more evenly split among the sexes. So about 52% of those diagnoses were among females that year. And we see variation there, but it's always around 50-50. We can talk a little bit more about the reasons for that later. I don't want to get too into that, but I will say that that infection is symptomatic more often. So folks feel compelled to go in when they have symptoms and maybe not think about it as much when they don't have symptoms for something like chlamydia, for example. That infection also affects younger folks, but it does trend a little bit older. So about 40% of the diagnoses are among persons under 25. But when we get to those under 35, we get to a majority of the diagnoses. The demographic breakdowns by race and ethnicity, also disproportionate rates there. Again, 54% among white populations in the state, 30% among our Black populations, and 6% among the Latino populations. And compared to the rest of the US, again, looking back at the 2020 national data, Iowa was 18th, so higher than average, which does not surprise me given that pretty steep increase we saw in the past 4, 5, 6 years prior to 2020. And then the last one I'll mention for now is syphilis. So we had 751 diagnoses in the state in 2021. Of those, 554 were infectious or early stages of syphilis. And I could talk a lot about syphilis, and maybe I'll wait to see if there's more questions about that. But what I will say is syphilis is a complex infection. It has various stages. But we talk a little bit more about the first 3 stages because those can be transmitted sexually. Some folks may not be aware that the late stage of syphilis, although it can cause very severe health outcomes for individuals, cannot be transmitted sexually. So that's why in public health we focus more on those early stages, the 554 number that I mentioned there. That one has tended to affect men more. So 77% of the diagnoses were among males. And that actually has decreased. It used to be that it was more around 90%. We can talk more about kind of the trends we've seen there, and I think that'll tie into some of the things Heather's going to talk about later as well. But we do see disproportionate rates there as well among racial and ethnic groups in the state. So 64% of the diagnoses were among persons who identified as white, 20% Black, and 10% Latino. And we have ranked lower compared to other states. So we were 40th in 2020. But what I will say about syphilis is that our rate of increase in the state has been, quite frankly, alarming. You know, nationwide, to see like a 50% increase, you have to go all the way back to 2016. We saw that type of increase in a single year. So even though we're still lower than other states, I don't think it's going to stay that way, especially when the 2021 and 2022 data the national data finally get worked out. And just one last thing, and then I'll pause, but I did want to also mention congenital syphilis. That's a very important infection. It's a specific way we talk about when newborns are infected with syphilis. So the infection can be passed to the fetus or can be passed during birth to the newborn. And it's a devastating infection. It can be deadly, it can be fatal, it can result in stillbirth. And when it doesn't, it can cause some pretty severe outcomes for the infant. In Iowa in 2021, we had 11 congenital syphilis cases, which I hope does sound alarming. Some people look at 11 and think that's not very many, but just to put that in context, the year prior we had 1. And that's kind of what we were used to seeing in the state, 1, 2, maybe 3 in a really high year. So that 11 in 2021 was very concerning for a lot of reasons. So I will pause there and I think turn it back.
Well, thanks very much. And let me have a couple follow-ups, but also encourage people, if you have questions from the audience, please send them in via Hpv. What is your thinking on why, especially with syphilis, but with the other ones, there's been this big rise? And is any of that increase due to people hearing about this problem and going out and getting tested more?
And I'll jump
Honestly,
into that, George.
Oh,
Yeah.
go ahead.
Oh, go
I was
ahead.
gonna say, I think what's concerning about this is we're seeing this rise and we have less people being tested.
Oh,
And
wow.
especially during the
Yes.
pandemic, we had less people going in for routine services and routine care. So the people that were being tested, more often or not, had symptoms prompting them to get tested. And as George alluded to earlier with his statistics, many of these infections have no symptoms. And so why it's concerning with infections such as syphilis, you may have symptoms and not realize what's going on. Those extreme early stages of syphilis may have no symptoms, or it may be a painless sore that's in an area of sexual contact that you're not going to see. So if it's in your rectum, if it's in your mouth, you may not even notice that you have the sore. If it's in the vagina, you may not notice that you have it, and it's painless and it goes away. And for many women, if they have chlamydia, they may not notice their symptoms and they're not getting tested. So we had a decrease in testing, but an increase in cases. So it is alarming and it is concerning. And there's many reasons why we had this decrease in testing. And part of it's the pandemic and resources being diverted. So public health resources were diverted during the pandemic. Provider offices were having to really limit the number of patients coming in to try to keep everyone safe from COVID-19. So we had those issues going on, and we had funding that was being diverted from many programs because of the pandemic. Resources were hard to come by. So I think a lot of people heard it, on the news that you couldn't get masks because masks were all being purchased. Well, that also went to the other supplies that we use for testing services. So there is multiple factors at play, but it's of concern that we're seeing this number when we had less testing that was happening.
That is really startling.
Mhm.
What do you think is the reason or reasons behind the spike in these cases?
So I think with things like syphilis, we've seen it spread into populations that weren't as affected in the past, at least in the recent past, I'll say. So we used to think of syphilis as an infection that primarily affects gay men and other men who have sex with men, at least in Iowa. And really it was, that population was disproportionately impacted in the US as well. And don't get me wrong, it's still a priority population for us, but as I alluded to, more and more women are acquiring the infection, and it's not much of a stretch to think that as more women acquire it, the greater the chance of congenital syphilis, which is what we've seen here in Iowa and in pretty much every other state in the US. So the fact that these additional populations are seeing these infections and becoming infected with them, really contributing to that. And there's a lot of reasons for that we can dive into here, but some of it is related to decreases in condom use that we've seen continually over the past several years. With things like syphilis, we are noticing more persons who use drugs are passing it within their social networks as well. And what Heather just alluded to, directly stated, decreased testing really fuels these infections. I mean, if you can diagnose and treat them early, not only are you doing a great thing for your individual health, but you're reducing transmission, right? But if folks aren't going in for more routine asymptomatic screening, what an excellent opportunity from a microbe's point of view to spread throughout the population.
And I think the other part of that too, George, is just sexual networks have evolved over time. And so your sexual network, you may only have one or two partners in your history, but they may have several partners. And so your chance of acquiring something in that social network has now increased. And technology has a lot to do with that too. So when I first began this work 12 years ago, most of the individuals that we would speak to when contact tracing for these infections would know partners through school or work or social groups. But now they're meeting partners through online tech apps, dating apps. And so these social networks are now huge, and trying to find all the people that are connected in that social network becomes much more difficult. And so that also is fueling this. And then I think we've done very good in some areas. Things like PrEP, which is a pre-exposure prophylaxis for HIV, has done wonders to decrease the ability of people to acquire HIV through sexual contact. But at the same time, that's decreased condom use in some of those social groups. Pregnancy prevention has also caused the condom use to be lowered. So if we're not using condoms, that also increases the chance of spreading these infections. So it's great that we have had some advances in our medical treatments that are out there, but because of that, we need to do a better job about talking about sexual health and how to protect yourself from these other infections that are out there. And a lot of that comes through educational efforts, starting in the schools. And in Iowa, it's kind of all over the board with what kids are taught in schools. Chapter 12 of the Iowa Code mandates that there has to be sexual health education in the schools, and you must talk about HIV, but it doesn't say how that happens. And so we don't have consistency across the board. And if we're not having that robust, comprehensive education in schools, if those conversations are not happening at home, then how do we get that education out to those individuals at a younger age? Because, and George, I don't think we went over that with the statistics, but when we look at STIs, age is a factor. And when we look at rates, it's that 15 to 24-year-old group that has the highest rate of STIs. So we need to be starting this education at a much younger age.
Heather, a couple questions. One, I just want to make sure I understand when you're talking about pregnancy prevention leading to less condom use. Are you talking like IUDs and implants?
IUDs, the pill. So women are not able to get pregnant because of these, which is great because we do want to decrease unwanted pregnancies. But at the same time, just because you're on an IUD, because you are taking the pill, you still need to be using condoms in conjunction when having sexual activity. And then we need to talk about the use of condoms with not only vaginal penetration, but with oral and anal sex too. And again, sex is a hard conversation.
Sure.
People don't like to talk about sex. It's uncomfortable. You know, you start saying these words and people start looking at you and kind of backing up. So at some point, we have to be comfortable with having these conversations about sexual health. Because we talk about mental health, we talk about physical health, we talk about our spiritual health, but talking about sexual health can be very uncomfortable for people. So it's working to make that as common as anything else that we're talking about, because sexual health is part of our overall comprehensive health care. So we need to be able to have those conversations and talk about sexual practices without that stigma and that bias behind it. And it's hard for medical professionals, it's hard for schools, it's hard for parents, it's hard for friends, but sexual health is part of our health and it is part of healthcare.
You do contact tracing, right?
Mm-hmm.
Talk to me, how does that work? Like walk me through how it happens and how has it changed both with the pandemic but also with the social networks?
Mm-hmm.
How do you deal with that?
So as George stated, we have 3 STIs that are reportable: chlamydia, gonorrhea, and syphilis. We also have HIV, which is a reportable infection in the state of Iowa. So when any of those are found at a physician's office or a lab, that is reported to the state. That is then that information is then relayed to the county or to the disease intervention specialist for that area. Thank you. Again, we have some name changes: disease prevention, disease intervention. So, but it's related to that individual. Then to follow up. So we're following up, one, with the provider office that did the testing, and we want to find out what treatment was administered, because it's really important that it's the right treatment for the right infection. And as George stated, when it comes to something like syphilis, depending on the stage of syphilis, how long they've had the syphilis, that will then determine what the treatment's going to be and how long the duration of that treatment is. For things such as gonorrhea, we always want to make sure that that's treated appropriately too, because we're seeing more and more drug-resistant gonorrhea. And so that's a real concern. What happens when we run out of medications that will effectively treat gonorrhea because of drug resistance?
And do people stop taking the meds because they think they're over it, kind of thing? Or
it can happen. So if you have a medication that you're taking a couple times a day over several days, compliance will drop because people start to feel better, and it's a long duration. So compliance can drop with that. So many of the treatments are shorter in duration because of that. We want to get people treated right away, but it's also that conversation. Just because you finish your medication doesn't mean the medication's finished working. And you need to wait a period of time so that medication can kill off all that bacteria, can kill off that infection before you can safely resume sexual activities. And then when you do resume sexual activities, what does that look like? How do you protect yourself so that you don't have this happen again, so that you're not spreading infection to others? So that contact tracing starts, first of all, with that call to the physician office to find out about treatment. And then we're calling the client, the person that tested positive. And what an uncomfortable phone call to get. No
So
one
how
likes
do
to
you do
get
it?
that phone call from the health department.
I'm the client.
Yes.
How does this phone call go?
So Tony, I would call you and I would say, Tony, my name is Heather and I'm from Lynn County Public Health. And we have been notified that you recently tested positive for an infection called chlamydia. So I'd like to talk to you a little bit about that and to go into some more background about the symptoms that you've had and some of the partners that you've had. And we want to talk about what you can do to protect yourself in the future. But I'm going to start asking you some questions, and they're personal questions. I'm going to ask you about your sexual partners and how long ago those sexual contacts were. And the reason is I need to make sure that those sexual contacts have been notified that they were possibly in contact with a sexually transmitted infection, and the importance of being tested and treated, regardless if they have symptoms or not. And so it's a difficult conversation. It's hard for people.
And how do they
have that
react?
conversation.
How do they react? How do they react?
Oh, it's all over the board. Some people will, they're glad you called. Some people are mad because they're mad that they have this infection, or they might be mad because somebody's calling them about this infection. They might be mad because it's a government official calling them about this infection. Other people are happy because they want to know that they're taken care of. They want to know that their partners are taken care of. And for some people, they're just kind of oblivious to it. They're like, well, I always knew I was going to get it. I kind of been waiting for it. And we'll just move forward. So you never know what that conversation is going to be like. But it's getting harder and harder to find the contacts for these individuals because many of them are meeting online and through dating apps. And a lot of that sexual contact is anonymous.
And so how do you do it?
It's very hard to find them.
How do you do it?
So we'll ask, well, what dating apps were you on? And did they have a handle? Did they have a name that they were going by? What did the picture look like? Can you describe this individual to me? What's their skin tone? What's their hair color? Do they have any tattoos? Any piercings? Any distinguishing characteristics? Do you know where they live? So we just keep trying to get as much information as we can to see if we can figure out who it might be. And sometimes I can't find them right away, but I might find them a few months later through a different investigation. So
and so do you as an investigator have a Tinder account and a Grindr account and all that and use it that way?
So we do have several different accounts that we can go on to, and we can look for people, and we can also direct message people through those accounts.
And what's the reaction to that?
Sometimes we don't get any responses. They will block us so that we cannot connect with them. Other people will call us back and they want to know that we're legitimate, that we're not trying to pose as somebody else, giving them bad information. So again, it's just trying to be very open, very honest, very transparent about who we are, why we're calling, and to offer them testing and treatment, and to let people know We're here because we care about you. We don't want you to have a sexually transmitted infection, and we don't want you giving it to somebody else. Because although many of these can be treated, they can cause long-term problems. Chlamydia and gonorrhea for women can cause pelvic inflammatory disease. It can cause them to become infertile. Syphilis can kill you if left untreated. So we can take care of that with an antibiotic. But again, we need to really go back to the beginning. We need to work harder. We need more funding to come through so that we can be preventative and stop this from the beginning, so we don't have all these infections transmitting within our communities.
Did the contact tracing fall off a little bit when, I mean, there so many people were involved in contact tracing for COVID.
Yes.
Did that put some of this effort on the shelf for a while?
We were still doing contact tracing during COVID, but it was not as robust. It was not even close as being as robust as what it was, because we had to divert so many different people to doing contact tracing for COVID.
And George, the state handles it for a lot of smaller counties, right? Was it the
Yeah,
same?
that's
Was
right.
that the same for the state, that you just didn't have as many people to do that because they were doing COVID?
Yeah, our DIS, disease intervention specialists, were reassigned to COVID for a time. Recently, they're working with monkeypox as well. So
Sure.
that did pull some resources away. But as Heather alluded to, we did try to keep up kind of the core services, especially for HIV and syphilis, our highest priority infections. Could I add just two things to build on what Heather said? One, I did want to emphasize with the contact tracing in the interviews, we call it partner services, usually in the STI field and HIV field. Our staff are very conscious of confidentiality, and they do really take every effort and go above and beyond to make sure that they have the right person on the phone. As Heather mentioned, these are sensitive matters. You don't want to get the wrong person on the phone, or get, as we sometimes do, a partner posing as somebody else, or getting their friend to pose as somebody else, or a parent posing as the adolescent, or what have you. So I did want to emphasize that. But I also wanted to emphasize, Heather is absolutely correct that with the apps and the anonymous partners, it has made it more challenging. But our staff has really done amazing things to adapt to that. I mean, she referenced, and you asked about the accounts that we're on to try to contact folks, but I am in awe. I mean, I've just seen, just this week, I saw a scenario with one of our staff, our DIS, who took initials like, TJ or something like that. That's all we had, and figured out who the person was, contacted them, and that day they were going heading into the clinic to get presumptively treated and tested. So it doesn't always work out that way, but I did want to say our staff have done amazing things. Their ingenuity is remarkable. And honestly, that is why when things like COVID come up, it's the staff that do STIs that are called upon to help out, because they have this skill set and this dedication. But again, as Heather alluded to, there's just not enough of us keep up. So.
Are they feeling any of the backlash that public health in general has felt from a fairly significant part of the population during the pandemic? And you guys have felt it. I felt it even writing about public health. I've been called a Nazi publicly for saying that vaccine was good. How does that affect this?
Yeah, it's hard. It's hard. I think staff, I'm fortunate. I have all my original staff that I started with before the pandemic, and I know a lot of people can't say that. And I have the staff here at Lynn County are absolutely amazing, and they are here because they are passionate about public health and about caring for the people in our community. But we see it all over the board. We see it both within our hospital systems, our medical systems. We see it in the state. We see it with our national partners. We've been beaten up pretty darn good by all sides, and it gets harder. And even when you're making phone calls to people and they find out that you're with public health, there's not the trust there because of COVID. And There's still that sense out there that this may have been a manufactured event, which it's not. COVID is real. And there's this sense out there that we're trying to push vaccines onto people to make money, which is not true. We do want people to be vaccinated because we know it saves lives. It keeps people out of the hospital system. It keeps our healthcare infrastructure intact. But it's been difficult and it's been hard. But I think the people that are here that are doing the work, again, are passionate about this work. They're here because they care about the community. They're here because they know that they can make a difference, and they just keep at it. So they're pretty amazing.
And you do feel like it leads to some more pushback on this part of public health too, that just that doubt about public health in general.
Yep. I think there's bleed over. George, you can speak for the rest of the state with the people that you see in the state DISs. So.
Yeah, we do see that too. We did see it before COVID, but I would agree that post-COVID, there's more of it. But, you know, like Heather said, we're fortunate in a lot of parts of the state to have experienced staff, and they can kind of roll with it as best they can and redirect it and really make it more about the client. And, you know, as Heather said, we're trying to connect you with resources so that you have better health outcomes, those kinds of things. I'd say most of the time that works out. I can't think of a lot of examples where at least that being the reason why somebody doesn't want to engage with us. There's plenty of other reasons why they may not want to engage with us, but I think our staff have done a pretty good job at redirecting folks when those things come up.
What are some of the other reasons?
Well, kind of what Heather mentioned. I mean, when you asked how people react when you call them, I mean, sometimes they don't want to deal with it. I mean, it's a tough thing, especially like if you're a partner or a contact and you don't have symptoms. You may not want to take that call because you got other things going on in your life. If you don't have symptoms, it's not going to seem like a big deal. You may be distrustful. You may think that whoever gave your name was lying, or, you know, trying to do a prank or something like that. And, you know, we do get questions like that, but that's pretty darn rare that happens. I mean, if somebody is going to give your name as a part of an investigation, there's a good chance that you've been exposed. But even if not, even when our staff get that kind of reception, we redirect, say, okay, well, maybe that's the case, but when was the last time you were tested for STIs? When was the last time you were tested for Chlamydia, Gonorrhea, Syphilis, HIV? And if they say, well, it's been a year, 2, 3, and we say, well, maybe it's a good idea to go in. It's been a while. And honestly, I mean, if we had more staff, we'd probably do things like that for more of the general population. We have to prioritize our resources. But yeah, I mean, folks have other things going on. Sometimes they can get angry. So.
And I think the other part of that too is they may be angry with us initially with the initial phone call, but there are several times, and I can think of several instances where they're upset initially, but then a month or so goes by and all of a sudden they're in the office. So it's that initial reaction to getting unexpected news. Yeah. And then once they've had time to process it and think about it, then they're ready to follow up. And we'll see that a lot of times with HIV too, is that initial reaction. It's hard, it's emotional. But after they processed it, then they'll call back and they're ready to start getting connected with resources.
Do you feel that the frontline doctors and other healthcare providers are screening enough for this? Or I sure don't remember, like when you fill out that questionnaire at the doctor's office, I don't remember anything about even related to this on it. Could we have some improvements there?
Oh yeah. Yes, we definitely can. Again, it can be uncomfortable. And I think the other thing to remember is post-pandemic, we have a lot of new providers. We've had a lot of turnover. So we have a lot of new nursing staff in clinics. We have a lot of new nurse practitioners, physician assistants, MDs in our clinics. And this may not be something that they've really had conversations with about when it comes to talking to patients. So it is, again, one of those things where we need to be more diligent in asking about sexual health and asking more in-depth questions. And then also keeping in mind all the health inequities that go into sexual health. So there's an intersect with a lot of the health inequities and sexual health. And so when you look at race, as George said before with the statistics, we see a lot more STIs in our Black, African American, and Hispanic populations here in the state of Iowa. We see it with age, with younger kids. So that 15 to 24 demographic has a higher rate of STIs. So having those conversations, looking at poverty. So our neighborhoods where there may not be as many healthcare providers, you may not see a healthcare provider as often. And if you're going to a healthcare provider because you think you have strep throat and you're not getting wellness exams, that question, like you said, Tony, is not being asked. We're just concentrating on that sore throat. So it's asking some more questions, getting more in depth. So substance abuse is another huge one. You know, when a lot of providers don't want to tackle these issues when it comes to substance abuse, and there's an intersect there between substance abuse and STIs. So it's looking beyond just the initial complaints of why somebody came in and asking some more in-depth questions, but that also takes time. And a lot of providers are trying to get as many patients as they can through their clinics. And so it's trying to take that step back and have those conversations, and for patients to feel empowered enough to ask for testing. But again, I think it comes back to funding again, because a lot of funding has been cut to clinics that provided STI testing.
I was going to ask about that. If I am just going for a normal physical in a, a Unity Point or Mercy or whatever clinic, and I ask to be tested, I'm probably going to wind up paying for that quite a bit, right? And it wouldn't be covered as.
Well, you may end up paying quite a bit, but they may only test you for gonorrhea and chlamydia too.
Yeah.
So it's also working with those providers. You need to be testing for syphilis. You need to be testing for HIV. Are you doing a visual exam? Are you looking for warts? Or are we talking about herpes? So it's having some more of those conversations too, and making sure it's a comprehensive sexual health exam and conversation. Because again, a lot of these infections can be prevented if we're doing things such as wearing condoms, decreasing sexual partners, getting tested often, asking our partners about testing and treatment. So how do we move that needle too? But again, a lot of our partners that used to do testing no longer have that capability. So here in Lynn County, we are now offering right now free at-home STI testing. So if you go onto our county website, if you go to Lynn County Public Health and look at health services under STI testing, you can register and have a free STI home testing kit sent to you. And then we also have a list of pharmacies that also have those kits available. And so individuals can go to any of those pharmacies to also work with the pharmacist and get one of those kits. And so that's available in both Lynn, Jones, Benton, and Tama counties.
Two questions. How are we doing on HIV? And also, why is herpes not included in this list? It's a very common infection.
Herpes is common. George, do you want to jump in there first?
Yeah, I can start with that. And I do think there's a lot of things to say about HIV as well, so I'm eager to dive into that. So herpes, yes, herpes is probably other than HPV, the most common viral STI out there. And there's a lot of feelings about herpes and a lot of stigma. Even though it's not reportable, I'll say most of the calls I get from the public when somebody wants to turn somebody in for spreading an STI, it's usually herpes. It's not syphilis or even HIV. But yeah, it is not reportable in Iowa, and in most other states, it's not a nationally reportable or nationally notifiable condition to CDC either. And the reason for that is public health tries to be pretty intentional about what they make reportable and what CDC asks to be nationally notifiable, in that there needs to be effective interventions from a public health perspective. And quite frankly, for something like herpes, there isn't. And here's what I mean by that. So with chlamydia, gonorrhea, syphilis, HIV, if you have been exposed to it, we have great, well, for the most part, great tests. There are some things I don't like about the syphilis test, but we'll put that aside for a minute. But we have good tests that can tell us whether or not you currently have the infection. We have presumptive treatment that we can give you so that if you have been exposed, it can perhaps prevent you from progressing and having that infection take hold. And so that makes contact tracing, there's something you can do about it. Now with herpes, if you don't have active symptoms, the testing it's not good. The blood test for herpes, I know a lot of people ask for it, they want it, but the results are confusing. It's prone to false positives. It does not tell you if you actually have the infection. It may tell you that at some point in your life you've been exposed to it, but that doesn't necessarily mean that you have it. And with that, there's no recommendation around presumptive treatment. So there's kind of a lack of action from the perspective of a public health or a DIS. You know, if I call you and say you've been exposed to herpes, I don't really have much to offer other than maybe keep an eye out for signs or symptoms. But
I mean, there is a
no
medication
testing to recommend.
There is a medication, right, to try to hold
There
it
is
down.
medication, yep, for people who are diagnosed. So for people who have symptoms, and there is a really good test for people who do have symptoms, who have sores. That test is good. You can do a swab. It's a PCR, a nucleic acid test, so it looks for the viral DNA, and that gives you a definitive diagnosis. It's the asymptomatic testing around herpes that is not good, but it is good for chlamydia, gonorrhea, syphilis, and HIV.
Yep. And the acyclovir that you're talking about can keep the symptoms under control, but you can still shed that viral material and you can still pass it to others. So it's not a end all be all. So herpes is a tough one, and there's a lot of herpes out there, and you can have herpes simplex virus 1, which is going to be more oral, or herpes simplex virus 2, which is going to be more genital. But we also see some crossover with that. So as George said, we'll swab somebody that has sores in the genital region and they're coming back as herpes simplex virus 1. Well, if I had tested a blood sample for that, 80–90% of the population is going to test positive for that because that's the common cold sore. So it's a difficult test.
And then on HIV, where are we at?
With HIV, so we're still having HIV cases. Our numbers, again, as a state, we're a more low incidence state, but we're still having cases and we're still finding more and more cases all the time. And again, I think we also have that intersect with substance abuse and the opioid epidemic, which is here in Iowa. And so we see more cases that are also coming from injecting drug use. So we have the sexual transmission and we have injecting drug use. Now we do have medication now called PrEP, the pre-exposure prophylaxis, which can protect you from acquiring HIV if you are at risk. However, we need more providers to be prescribing that. We need to have more conversations between clients and providers about risk factors for that, and knowing that people that are injecting drug users, people that are maybe sex workers, as well as those in the LGBTQIA+ arena, having access to PrEP. So we need to make sure that those conversations are happening so that people can have access to PrEP. We do PrEP here at Linn County Public Health, plus there's a PrEP coordinator for the state. So if anyone is having troubles trying to get a hold of PrEP or trying to get appointments for PrEP because of where they live, they can contact the PrEP coordinator who can work with them on telehealth visits and different things so that they can get their medication. So PrEP is great, but we're still seeing cases of HIV. It's not going away. It has not. I don't have the numbers in front of me to say it's going down or that it's stable, but we're still seeing cases here all the time. And it's, again, multiple reasons. Injecting drug use and sexual activity are the primary factors of why we're seeing HIV cases.
Is anybody tracking how many people are on PrEP and where they are? Like, are there
So it's there. Here in the state, we have our Ryan White case managers, plus we have public health. And so we're really working on what they call re-engagement. So working to find individuals that have been diagnosed with HIV, making sure that they're on their medication, that they're taking their medication, and asking them about their partners. So if they have a significant other, is your significant other that may be HIV negative? Are they taking PrEP? Can we help keep them on PrEP? But again, this is voluntary. It's not mandatory. So I can't watch everyone that's taking it because this is something voluntary. Nobody has to take this. So there may be someone that starts it, that stops it. We're not tracking that per se. Plus, we have a lot of people that move in and out of the state. So we'll have people moving into Iowa. And so if they reach out to us, we can help get them engaged with providers out here so that they can continue with their PrEP therapy. But then we also have a lot of people that move out of Iowa. And so then they're looking for PrEP providers wherever they moved.
Yeah, can I add a couple of things to that?
Of course.
So there are some pretty good data out there for PrEP, and nationally they're trying to do a better job of tracking who's uptaking it. They have to pull some de-identified data from insurance and things like that. But there's a site called AIDS VU, and they have added in PrEP in there, so you can kind of get a picture across the country of PrEP uptake across the U.S. So that's a helpful tool. But I did want to add to what Heather said with HIV. I mean, there have been a lot of resources poured into HIV, and I think we've seen the benefits of that through the amazing strides we've made with biomedical interventions for HIV. For folks who've been around for a while, I mean, there used to be not a whole lot we could do with somebody with HIV except for management. And now with the medications that Heather has mentioned here, we're really trying to continue to promote this thing called U equals U that Heather was getting at, undetectable equals untransmissible. So if somebody who has HIV is on medications, they can achieve an undetectable viral load, which essentially means they cannot transmit that virus sexually. So not only is it excellent for their health outcomes, it's excellent from a public health perspective because that stops the chain of infection. So that re-engagement that Heather was referencing is something we are putting more and more resources toward to try to help individuals and try to help public health as well. So that's something I think stands out. Well, there's a lot of things that stand out about HIV, but the biomedical interventions have been so phenomenal. I would love to see some of those for the other STIs. I mean, honestly, we're lucky to see an innovation once every 20 years. There are some things that we're hoping for on the horizon with, we're hearing about things now called like doxy-PEP, doxycycline that could be used for more often to try to reduce syphilis acquisition, and it would have a side benefit with chlamydia too, since that's used to treat chlamydia. And Heather referenced gonorrhea before and antibiotic resistance, and we are sure hoping that we can find some more drugs for that because we're on our last line. We're using the cephalosporins in late 2019. CDC recommended doubling the dose of that. So that's great, but there's only so many times we can double before it's not gonna be tolerable anymore. So I would love to see some more support and research and funding for biomedical interventions for the other STIs.
And George, to piggyback on that too, I think it's important to remember we do have a vaccine that helps to prevent HPV. So we have the HPV vaccine. HPV can be sexually transmitted. And so we have a vaccine out there to prevent the cancers associated with HPV. So again, we don't like to talk about HPV vaccine because there's that sexual connotation behind it, but that is a cancer vaccine. Yes, HPV can be transmitted sexually. We all know that, but with HPV, even though you may not be sexually active, because we have this conversation with parents all the time, your child is not sexually active. You don't know what the future is going to hold for them and who their future partner may be. So if you can protect your child from HPV related cancers, that's a huge win. And so we do need more research in that arena. So.
And what does the uptake of that look like? And has it changed with the backlash against vaccines in general?
So it's never been great. So depending on where you're looking, you're about 40 to 50% of that age population that's being vaccinated. So it's not great. So in the state of Iowa, we have different immunization coalitions that are looking at how do we get the information out there to see if we can increase uptake of HPV vaccine. It's not a required vaccine. Other vaccines in the state are required vaccines. This is not a required vaccine. But again, it's having that conversation that, yes, your child would have to come in and be vaccinated for this. And we know the younger they are when they get vaccinated, the better the body's response to that vaccine is, and the higher that immunity impact will be. So we want those kids vaccinated at a younger age. We want them vaccinated at 11 and 12. We don't want them waiting until after their sexual debut to start vaccinations. So it's really having those conversations and working with pediatricians and family practice providers to really integrate that conversation into those wellness visits that kids are still having with their primary care providers. But again, it's not just HPV. Those providers need to be talking about sexual health with their children at those visits, because we want to protect them with HPV, but let's talk about what is sexual health. And sexual health is also your dating relationships, and it's how to be safe on the internet and social media. And so sexual health can be big, and that's why that education is so important. And we need to be able to have those conversations with our providers' offices, in the schools, and with parents.
Do you think that happens very often with providers, with somebody who's 12 or 14?
Not enough. Some providers are great. Some are very, very good. Others, it's an uncomfortable situation. It's an uncomfortable conversation for them.
Mhm.
George, do you have anything else on that? I had one more thing I wanted to cover.
Just related a little bit more to some of the earlier conversation on providers, and keep in mind that with the increases that we've seen here, some providers who've been around aren't used to seeing it. So especially syphilis, like I can't tell you how many times I've taken a call from a provider who would say, like, I didn't even know syphilis was still around. So, I mean, I think that's something else to keep in the back, or maybe not the back of our minds, maybe the forefront is making sure we're raising awareness among the medical community as well.
Does that keep them from like thinking of it? Like if they...
Yes, it does. Yeah, it doesn't. I mean, I'd say for the most part, they're good about things like chlamydia, which is, well, better, which is much more common. But yeah, when we kind of do these key informant interviews, they just say, well, in training, I was never taught much about syphilis because I was taught it was rare and only for, very specific populations should we be thinking about it. And as I mentioned at the beginning, that's no longer the case.
Well, we're almost at time. I wanted to ask you real quick, if you know that the preferred way to refer to this has switched from STDs to STIs. What's the thinking behind that?
That's actually a hotter debate than you would think in the field. But generally, two things with infection instead of disease. One is infection tends to be a less stigmatizing word than disease. So since we're really trying to chip away at stigma, which I would argue is at the core of most of our problems with STIs. That's one reason. The other is that in the strictest sense of thinking about what disease means, its definition, it's a little too restrictive. Disease, people often think of as having symptoms that you can notice. So that kind of removes all these asymptomatic conditions that we've talked about. Whereas an infection, you can have infections that are asymptomatic. So that's a couple of the reasons.
That makes sense. Well, we're just about at time. If either of you have a last thought you'd like to impart about what needs to be done here.
I would just encourage people to, I'd say I'd encourage people to talk to their schools, school boards, PTOs, talk to your providers, your friends about sexual health and where are we doing education for sexual health? Because again, I think it's imperative that we really get this back into the schools and that we're is a K through 12 curriculum. There have been some good ones out there, but it seems like it's getting pulled back more and more and more. So we really need to start this conversation at a much younger age, especially when we're looking at the data that shows us that children 15 to 24 are, that's the age group where we're seeing this the most. And that's just, that doesn't say that we aren't seeing children younger than this. So we have seen children much younger than 15 that are diagnosed with STIs. So we need to have that conversation. So talk to your PTOs and your school administrators, your school boards about where is sexual health in their K through 12 curriculum. And then talk to your doctors and make sure that that's part of the conversation that you're having, and talk to your friends and that they're having that conversation too. And when they go in and they ask for STI testing, as George said, I'm asking for gonorrhea, chlamydia, and for syphilis, and for HIV. That is a comprehensive sexual health history and examination that I'm having done.
George, parting thought?
Yeah, just taking a tangent from that. I firmly believe that all of the stigma that's abound in this country around sexual health, and specifically STIs, is what's fueling the spread. I mean, we can talk about the biomedical reasons, the way the microbes spread, the social networks, that all is valid. But I think by doing these things that Heather has just described, by talking about them, we can start to reduce the stigma. We should know by now that ignoring a problem doesn't make it go away, and shaming people for it does not make it go away, it just fuels that spread. So that's one thing I really want folks to remember. And the other is what we've touched on a few times here today, and that Heather's done a good job of highlighting, of the health inequities. It's not a coincidence that the same marginalized populations have disproportionate rates, not just of STIs, but of other health conditions. If you look at heart disease and cancers, I mean, we see this over and over. There's a lot of systemic things, whether it's related to access to healthcare or access to other resources, historic mistrust of the medical system for some reasons that we didn't get into today. We need to have those at the forefront of our mind too, if we're really going to be trying to work with communities to encourage testing, to make it available to them in a way that they can access it. And the things that Heather mentioned with like the at-home testing is a great step toward that. So I hope that we can work with communities that are disproportionately impacted to develop more of those. But again, we need some support to make those things happen.
Well, I appreciate your time so much. Thank you guys very much. And I hope the audience found it helpful.
Thank you.
Thank you. Appreciate the opportunity.